Excellent. All right, so I'm going to start off just with a very brief overview of our pharmacogenetic testing service at Cincinnati Children's. There is a publication from several years ago now, but it started in 2004, so even before CPIC was a thing. There was a patient who had a bad reaction to an SSRI, and his father was a neurologist here who was interested in genetics and approached the genetics division and the pharmacology division and said, what can we do to help predict these kinds of reactions for other kids? And they launched this service. And it turns out his son was a CYP2D6 poor metabolizer, no surprise there. And in 2004, they started the service, and then the Department of Psychiatry here made the testing for CYP2D6 and CYP2C19 part of routine patient care. So every child that gets admitted to the psychiatry unit here gets the pharmacogenetic testing, and they have since 2005. We have the largest pediatric inpatient psychiatry unit in the country with more than 100 beds just dedicated to psychiatry, and they're building another building as we speak. So we have a lot of data about psychiatry pharmacogenetics here in Cincinnati. So there are some other units that also include the testing upon admission as part of a standing order set, like for a kidney transplant, for bone marrow transplant, and new oncology cases as well. And those are more recent additions, not been going since 2004. So to date, we've performed more than 35,000 tests in-house, and we use on-site testing with a panel of genes. Right now, we're using the Agena mass array platform, and previously we used a TACMan low-density array with a long-range PCR for the CYP2D6 deletion and duplication, but now the mass array does the duplication and deletion detection for us with their CNV kit. So the results are reported into the electronic medical record within about 2 business days is our goal for the service. And they are discrete data, but only for the genes that the provider ordered. So if they ordered a psychiatry panel, they get CYP2D6 and CYP2C19. They do not get CYP3A5 or CYP2C9. They only get what they order. But there is a comprehensive panel that is now being ordered by the bone marrow transplant and the oncology teams because they use a lot of medications that are metabolized by all of those enzymes. So the phenotypes are what is included in EPIC, and there is clinical decision support for ordering the pharmacogenetic testing and for going to view the results. The alerts are not as informative as I would like them to be, but it does say to go look at the results, and they're there. So at any rate, now the drug we're going to talk about today is Risperidone. And as I'm at a pediatric hospital, I'm going to talk about the indications in children and adolescents. So it's indicated for schizophrenia, bipolar disorder, and irritability associated with autism. But it is also used to manage aggressive behavior and psychosis in patients with other mood disorders. So risperidone is metabolized by CYP2D6 into 9-hydroxyrisperidone, and this 9-hydroxy metabolite is active, and it is also a drug that can be prescribed called Paliperidone. So there are oral versions as well as intramuscular injection versions, long-acting forms of these medications. But I said it's metabolized by CYP2D6, but that's the major metabolism pathway, but that's not the only pathway. So there are minor metabolism pathways through CYP3A4 and 5, and then UGT1A1 as well. So risperidone and paliperidone, though they are very similar, they are just a little bit different. The interaction here with each of the receptors in the brain are shown here. So the 5-HT2A is a little bit more strong of an interaction with risperidone than paliperidone, and the D2 is about the same, and it's this interaction that causes the hyperprolactinemia that we will talk about today. So there are several side effects of risperidone and paliperidone, like extrapyramidal effects, weight gain, and hyperprolactinemia. This is a second-generation antipsychotic medication, so weight gain is a definite known side effect in a lot of people. And a lot of these medications can result in discontinuation or non-adherence. If they don't like the side effects, they'll just stop taking it, especially in teenagers. So that's where some of the more long-acting forms come in and help with that. I did want to point out that there was a big lawsuit several years ago about risperidone, where Johnson & Johnson had a jury decided they should pay $8 billion because they downplayed the risk of hyperprolactinemia and breast growth in boys. But later that was decreased to $6.8 million, but still a substantial payout. So there are no CPIC guidelines, but there are Dutch Pharmacogenetic Working Group guidelines. CPIC has just begun the literature review for the antipsychotic guideline, and I know some of the authors are on the call today. So for the Dutch group, they, in the CYP2D6 ultra-rapid metabolizers, they tell you that the percentage of patients with therapy failure increases in this group, and it leads to a high ratio of the active metabolite, the paliperidone, compared to the risperidone, and the risperidone crosses the blood-brain barrier more effectively. So their recommendation is to choose an alternative or titrate the dose higher. In the IMs, the intermediate metabolizers, there is no recommendation. And for the poor metabolizers, they also say that the percentage of patients with therapy failure increases, and the concentration of risperidone to paliperidone is increased. So use 67% of the normal dose. And if side effects occur despite the reduced dose, then reduce it further to 50%. So now I'll talk a little bit about hyperprolactinemia. It is caused by the dopamine D2 antagonism in the anterior pituitary gland. And so what this looks like in females is menstrual disturbances and hair growth. In males, it's gynecomastia and oligospermia. And then in both sexes, it's galactorrhea, infertility, acne, migraine, and sexual dysfunction. So there have been some studies that have shown larger increases in prolactin levels in pediatric patients compared to adults. So this is definitely something that our pediatric providers are worried about and are assessing. And there has been several studies. This is sort of an older one in adults, but there has been a similar one in pediatrics to show that there is a stronger association between the prolactin levels here on the y-axis and the concentration of paliperidone compared to risperidone. So the paliperidone, as in the blue, can see that as a stronger association than the risperidone concentration with the prolactin that's shown in the red. So you might think, well, if it's associated more with the paliperidone, then perhaps there will be more hyperprolactinemia in the patients treated with paliperidone. And it would be nice if that data existed, but I looked long and hard and could not find much besides this meta-analysis that shows that the prolactin level increases in both the paliperidone and risperidone treated patients, and the frequency of hyperprolactinemia is almost 30% in the risperidone, but they didn't report what the frequency was in the paliperidone trial. But they do show 2% of patients had prolactin-related adverse reactions, and only 1% in the risperidone group. So it does look like a little bit more prolactin-related adverse reactions in the paliperidone treated patients. So we did a retrospective study here at Cincinnati Children's and looked at patients that were treated with risperidone and paliperidone that we had CYP2D6 genotypes on, and found that the dose of risperidone was needed to be higher in the poor metabolizers to cause hyperprolactinemia than in the intermediate and normal and ultra rapid metabolizers. So this supports the idea that perhaps it's the paliperidone, and you need, since the CYP2D6 poor metabolizers are not producing very much paliperidone, they you have to have a much higher dose to get the level that will produce the hyperprolactinemia. The association was not there for the paliperidone treated patients. So we have sort of, oh, that looks kind of funny, but the sort of a teeter-totter between the balance between paliperidone and risperidone is different between the CYP2D6 poor metabolizers and the normal or ultra-rapid metabolizers, where they are making, the ultra-rapid metabolizers are making more of the paliperidone. They might be at higher risk for hyperprolactinemia, but perhaps less risk for weight gain that is more associated with the risperidone concentrations. And the CYP2D6 poor metabolizers, they might be at bigger risk for weight gain, but have less hyperprolactinemia given equal dosing.